Hello, so now we'll talk about athletic pubalgia. The first question when treating athletic pubalgia is, does it exist? And I feel sometimes that my words collide when I'm talking about athletic pubalgia, because I think hip preservation specialists and sports medicine specialists think very differently about athletic pubalgia. The world of a hip specialist surgeon revolves around the hip joint, and usually people will just think that FAI and other interarticular causes will cause hip pain. This is when I was in 2013, Professor Guns came to the Brazilian Hip Society meeting and I presented about hip pubalgia, and this was my great opportunity where I divided a panel with him, and he basically said that athletic pubalgia did not exist. He believed that soft tissue problems would not cause hip pain. On the other hand, especially here in Brazil, I would say the sports medicine specialists feel all the time the pain is related to athletic pubalgia, and we all know that is not true. So probably we'll have to find a balance between the diagnosis of athletic pubalgia and FAI. So what is athletic pubalgia definition? The definition that I like is thinking about athletic pubalgia as a syndrome, and it will be defined as pain in the pubic region and or the groin, not related to the hip joint and not related to inguinal hernia. We believe that the main problem in the athletic pubalgia is a muscle imbalance between the rectus abdominis and the adductors, and we did some work showing that the rectus abdominis tendon is continuous with the adductor tendons. An imbalance in this muscle would lead to pain. We don't believe that the pubic symphysis joint itself is a cause of problem. I think in the athletic pubalgia as a diagnosis of exclusion. So we have to make sure that the hip joint doesn't have problems and that the patient doesn't have an inguinal hernia. For looking at the hip joint, we always have to have AP-pelvic x-rays and bilateral hip joint x-rays, as well as bilateral hip MRI to make sure that there's nothing in the joint. So the patient that has athletic pubalgia sometimes need 3 MRIs, MRI of the pubic symphysis, the right hip and the left hip. And it's very common that even if this imaging, we're not sure about where the pain is coming from. So in these cases, a therapeutic test injecting the joint to make sure that the pain is not coming from there, it's very important. On the other side, it's very important to make sure that the patient doesn't have an inguinal hernia. And in patients with athletic pubalgia, I usually do a physical examination of the inguinal canal, which is something that we're not very used to do, but it's important to do it to train yourself to make sure that the patient doesn't have a hernia. And the ultrasound would be very important in this as well. So this is a case of a patient, a Brazilian track and field athlete, very high level, who was dealing with athletic pubalgia, at least it was thought it was athletic pubalgia, and when he came to me, I diagnosed an inguinal hernia, he got operated and got back to his activity. So this is still very common. But I have a problem in Brazil. I'm not sure how it is in Israel, but general surgeons in Brazil are not very used to treating athletic pubalgia. So this is a problem, because sometimes I'll send patients to a general surgeon with a small hernia, and the general surgeon will tell the patient that it's not the case of his pain is not coming from the inguinal hernia. But I really believe that small hernias can hurt, and it's important to treat most of the time surgically, even these small hernias. Also, there's the concept of the sports hernia. This is the concept by Dr. Munchavec from Germany, where it's just a weakness of the posterior and not a true hernia that can compress the genital femoral nerve, and this can cause pain. And these patients will be treated with surgery, usually just making a reinforcement of the posterior wall, and this is really important to know. Another really important aspect when treating athletic pubalgia is the relationship between pubalgia and FAI. I feel like there's this scenario where I have patients with pubalgia, some patients will have articular hip pain, some patients won't have articular hip pain, and some patients will have FAI anatomy, and some patients won't have FAI anatomy. So how does this work? When you have a patient that has pubalgia, doesn't have articular hip pain, and doesn't have FAI anatomy, this would be what I call a classic pubalgia, and we treat it just like as pubalgia. When you have a patient that has pubalgia, doesn't have articular hip pain, and doesn't have FAI anatomy, this is the patient that needs thorough investigation, because we're not sure here what this patient have, and he need a more specific investigation. Then you have two typical scenarios which are really confusing. One is the patient that has pubalgia, has articular hip pain, and has FAI anatomy. In this patient, probably the pubalgia is secondary to the FAI, so you should treat first the FAI. But it's important to, even surgically most of the time. But it's important to tell this patient that it may take longer for him to get better. It's not uncommon that this patient will get better from his joint problem, but he'll still present some symptoms of the athletic pubalgia. And it's important to tell the patient as well that pubalgia may need later treatment later, sometimes even with surgery. So counseling the patient in this case is very important. And then you have the case of a patient who has pubalgia, doesn't have articular hip pain, and has FAI anatomy. I don't think we have supporting literature to know how to treat this patient, because probably his pain is secondary to the FAI. But if you think about treating the FAI, you'll probably be treating an asymptomatic joint. And should we do that? So personally, I treat the pubalgia, sometimes even with surgery, but it's important to advise the patient what you're doing. And sometimes advising them that the literature does not support, at least doesn't have strong evidence of what to do. And also explain to the patient that sometimes he will develop intra-articular symptoms later, even sometimes he will need surgery for the intra-articular problem. I always start the pubalgia treatment conservatively. And actually, before treating the patient, prevention is very important in athletic pubalgia. We usually do a lot of core strengthening, and we've seen a decrease in the incidence of pubalgia, probably because people do a lot of core strengthening nowadays. This is the 11 Plus program of FIFA, which is a program developed for preventing problems in soccer players. And also the decrease in incidence is probably related to better understanding of FAI. Some of the patients that were thought to have pubalgia had FAI in the past. Rehab is very important. Rest from athletic activity, and this is very hard because the patient usually they get better really fast when they start resting, but then they get symptoms when they try to go back to sports. And PT, which I believe it's important to do formal PT. You can also do injections, both anesthetic for diagnosis and cortisone. You can inject both the rectus and adductors, it's usually what I do most, and sometimes the symphysis itself. And what is the surgical treatment? In the literature, you can find many different treatments for the hip pubalgia. And usually these diseases that have lots of treatments, it's because none of them works really well. Personally, what we do is it's a technique where we do a tenotomy of the rectus abdominis and a bilateral tenotomy of the adductor longus for the same incision, which is a funny steel surgical approach just above the pubic symphysis. Our results we published already. It's 45 athletes, from whom 35 were professional football players with a mean age of around 20 years old, and they all returned to sports. We had 2 hematomas that needed drainage, 1 superficial infection that subsided with oral antibiotics, and 1 patient needed a new tenotomy. So my take-home message for athletic pubalgia patients is athletic pubalgia exists. You have to exclude FAI and inguinal hernia. It's probably one of the main lessons from this talk that I wanted to give to you. You should initiate the treatment conservatively, and surgery have excellent results when PT fails. Thank you very much.